when is surgery indicated in those type of cases is a big question. So to help answer that, we're going to bring in our good friend and colleague, Dr. Hooman Melamed. What are your thoughts on Alan's claims that most chronic pain is not caused by structural damage?
I like to respectfully disagree with that, but I think there is some, I do agree with some of the points. The 80% of the adult population in the world, they get back pain at some point in their lifetime. And we do know that some of them end up obviously developing chronic pain. So you need millions of people in a study to validate what Alan is saying.
Alan, what questions do you ask patients when trying to make that determination? Is pain between the ears, or is there structural damage going on that probably should be best addressed?
There are some things that we look for to help make this determination. Did the pain come on during a time of stress? I used to have chronic pain, and my pain came on when I was in graduate school. A lot of stress, a lot of pressure. Another thing that we look for is sometimes the pain could start with an actual injury. The brain could learn and remember the pain, and the pain can persist even after the injury heals. Another thing that we look for is, does the pain spread or move around from location to location? That's something that isn't necessarily consistent with structurally caused pain.
It's curious, Alan, because and imaging is one of those things we would use in this case, but Alan, you say that in most cases, no imaging studies are needed to determine if pain is all in one's mind. Tell us about that.
Sometimes imaging definitely is needed, as I'm sure Dr. Melamed could attest to. But sometimes getting an MRI can be a double-edged sword. You know, when I had chronic back pain, I got an MRI, and I remember a physical therapist looking at this MRI slide, and she said to me, "Did you fall off a third-story balcony or something?" It was terrifying, you know, and I was ultimately diagnosed with disc herniations, disc degeneration, kyphosis of the spine, moderate arthritis, and it was very scary, but none of these things were actually responsible for my pain, but it did cause me a lot of fear.
Dr. Melamed, I mean, what are your thoughts on Alan's claims that undergoing imaging studies can actually do more harm than good?
I think most patients do need imaging done because you don't want to miss patients who have cancer. Because I had a friend who passed away from cancer at a young age, who the doctor kept blowing him off. I have back pain. You're just stressed out. Like literally, just do, you pull your back, you'll be fine. 3 months later, the guy collapsed, massive cancer spread from his colon. And then 2 weeks later, he passed away. It was very tragic. This was 25 years ago. I'll never forget it. So I do think if you have back pain more than 4 weeks, 6 weeks, you gotta get the imaging. But I do also agree, it's how you talk to the patient that yes, if you tell the patient in a bad way, it could be a double-edged sword. You could mentally cause problems with the patient. So I think that part is important. But I do think most people need the imaging study done to rule out, God forbid, cancer or structural, because you don't want a structural problem that could be treated easily surgically go on, because that will cause chronic pain. And even if you take care of it structurally, then that patient is not going to get better right away. I do believe the pain gets embedded in the brain. So you don't want to miss structural problems early on because you want to get to them right away, because you don't want that patient to develop chronic pain because of that structural problem.
Dr. Melamed, that's such a great point. Imaging is one of the tools we have in our toolbox to make sure we don't miss the big things. God forbid, something that we could catch and fix early.